Hello and welcome to our webinar. My name is Michelle Brunson. Presenting with me today are my colleagues Sandy Swallow and Kelly Smith. Thank you for taking time to join us for our webinar, a closer look at the performance requirements for MIPS in 2019. While we will try to provide basics and a little more, there's no way we can possibly go into the level of detail we would like to in an hour. So just know we will be giving a presentation on each category starting in the new year. I would like to remind you that if you would like to download the slides, they will be available here hopefully by today at telegenqpp.com website under the Resources tab and Webinars. Following our discussion, you will receive a survey. We ask that you please take 5 minutes to complete it. We really do value your feedback you share with us, and it helps us plan and prepare for other webinars, as well as determine where more technical assistance is needed. So who are we? Many of you are familiar with us, but those of you who don't know us, all three of us work for Telegen in the West Des Moines, Iowa headquarters office. We work closely together on 2 separate support contracts funded by CMS, and we provide no-cost technical assistance, resources, and support for eligible clinicians and their organizations participating in the Quality Payment Program. Kelly and I, along with our team, work with those in the small, underserved, and rural practices with 15 or fewer clinicians in Iowa, Nebraska, North and South Dakota. And Sandy and her team work with larger practices, health systems, and ACOs in Colorado, Iowa, and Illinois. So if you're joining us from another state today, welcome. We're glad to have you. And if you have any questions about how to reach the SURS or QIOs in your state, we would be happy to connect you. Today, we will have a quick review of eligibility for the MIPS program, and then the bulk of our time will be spent looking at each category in detail. We'll share some tips along the way and then open up the lines for your questions. We do have a lot to cover, so let's get started. Before we go deep into the categories, I do want to remind everybody that there are 2 ways to take part in the Quality Payment Program, either through the Merit-Based Incentive Payment System, or MIPS, or in the Advanced APMs. And today our session will focus on MIPS and MIPS APMs. Those MIPS APMs are a subset of both those participating in the MIPS and the Advanced APM path. So we will discuss both of those today. And we're going to start off exploring MIPS eligibility for 2019. If you are a MIPS or MIPS APM eligible clinician, you will be subject to a performance-based payment adjustment through MIPS. And to be included in MIPS, you must be a MIPS eligible clinician type and meet certain thresholds of participation in Medicare Part B. So on the left-hand side in the box, you're going to see the MIPS eligible clinician types. On the top are the types that have been included since the beginning of the Quality Payment Program in 2017, and those are the physicians, PAs, nurse practitioners, clinical nurse specialists, and CRNAs. New in 2019, we have some new eligible clinician types, and so those include clinical psychologists, physical therapists, occupational therapists, speech-language pathologists, audiologists, and registered dietitians or nutrition professionals. Now, to be included in MIPS in 2019, you must be one of those eligible clinician types, and you must exceed all 3 elements. So new in 2019, they have added a 3rd element. So as in 2017 and 18, you must, or as in 2018, you must bill more than $90,000 in allowed charges for covered professional services under the Medicare Physician Fee Schedule. And you must also see more than 200 Medicare Part B beneficiaries. But new in 2019, you must provide more than 200 covered professional services under the Medicare Physician Fee Schedule. And just a side note, with this eligibility expansion, CMS projects that the increase in the MIPS eligible clinicians will go from 620,000 to 800,000. So also to note that in 2017, there were more eligible clinicians reported at the group level than in the prior program of PQRS. So, all right, now we're going to talk about how not only has the MIPS eligibility and low volume thresholds expanded, but also the participation options have expanded for 2019. So the MIPS determination periods, there are 2 determination periods, and the first one will run from 10/1/17 to 9/30/18, and that does include a 30-day claims run out. The second determination period for MIPS will run from 10/1/18 to 9/30/19, and that does not include the 30-day claims run out. So there are 2 different ways that you can participate in the program. The first is not new. You may voluntarily participate, and what that means is that you can submit data and receive your performance feedback, but you are not subject to a payment adjustment. The new option in 2019 is that if you meet or exceed at least one, but not all of those low volume threshold criteria as we showed in the previous screen, then you can opt in. And this is different than voluntarily participating because first of all, you must make an election to the program. You must let CMS know that you're going to opt in. Now, this hasn't been determined how that will look and what that will look like yet, but it is something that is different than voluntarily participating and deciding last minute you're going to submit data. When you opt in, you make that election, just know you will be subject to MIPS performance requirements and a MIPS payment adjustment. And that was really at a request of a lot of these eligible clinician types that want to be included in MIPS, and so it provides that flexibility to do so. So now, how do we check the QPP participation status? So this is really the first step for 2019, determine who is eligible. And one of the 2 ways that you can do that depends on the size of your organization, really. You can check your individual status by entering your 10-digit MPI number and on the QPP participation status tool. Or using your organization TIN, you can use your enterprise identity management credentials and the appropriate user role associated with your organization login and look at the connected clinician list for your organization. CMS, they have a goal that they will have that first determination period for 2019 status by the end of December or early January. So look for that to be coming here shortly. Now, the second step is to strategize which level of reporting meets your organization's financial and quality goals. There are 3 levels of reporting options. They remain the same as last year, so either individually or as part of a group or as part of a virtual group. And there is a virtual group toolkit that is available. It's a wonderful toolkit that we highly suggest you take a look at if you are interested in doing this, but just know that the virtual group application must be completed by December 31st of 2018. Now, step 3 is really to set your performance and financial goals. And sometimes the best way to do this is really look at what you've done in the past and compare that to how you're doing right now in 2018 and what you want to, what are your goals for 2019 and what changes maybe have been implemented that maybe make you look at things a little differently. So the performance threshold has increased from 3 points in 2017 to 15 points this year in 2018, and in 2019 that increases to 30 points. So is that doable for you? Is that something that you would like to do? And I hope that you say yes. If you do that and you meet that threshold, you could avoid the negative payment adjustment. Now, on the other end of the spectrum, if you're an exceptional performer, then you would score points of at least, in 2017 it was 70 points, in 2018 also 70 points. 2019 they stepped it up a little bit, and it's now 75 points coming into the 2019 year. So along with those performance thresholds ramping up, so are the payment adjustments. They're making more of a financial impact and more significant than in the first year. We showed there was a negative 4% penalty if you didn't perform in 17. In 18, a negative 5%, and that increases to a negative 7% for 2019. and even a negative 9% in 2020. So you can see that they are really increasing that negative threshold, negative payment adjustment for the penalty. And the exceptional performer bonus, remember this is a budget neutral program, and so those that don't perform will pay in for those that do. And so the max that was received for those exceptional performers for the 2017 year was positive 1.88%. And CMS, in the final rule, they did some predictive modeling, and they expect to see a 2% for this year and then up to a 4.7% reward for exceptional performers in 2019. So with that, I'm going to turn it over to Sandy to talk about the quality and the cost categories.
Thanks, Michelle. And I want to start by just saying that this slide deck was built to be a reference for you folks. So I don't plan to read or discuss every detail on the slides just due to the time constraints, but as Michelle said, stay tuned for future webinars that will be specific to each performance category where we'll do a little bit deeper dive. However, if you have questions about points on the slides, be sure and write those down and just save those for the Q&A session at the end. I'm going to start with the quality performance category, which continues to be the highest weighted performance category, and where we expect to see the benchmarks getting tougher and the bonus points have been limited. CMS has weighted this to 45%. You'll report on 6 measures with at least one outcome or high priority measure for at least 60% of the eligible instances and a full year of data. There is partial credit awarded for reporting fewer than 6 measures and also opportunities for bonus points if you report over 6. And we'll talk about that in just a few minutes, the bonus points. The case minimum is 20. And now I always have questions from folks about data completeness, and what that means is if you look across the entire population of patients for a particular measure denominator, you must report on at least 60%. So for example, if you were using claims as your collection type, you'll have to report on 60% of the Medicare Part B claims for the population that fits in that particular measure. Or if 60% of the patients across all payers if you're using collection type QCDR or a registry or an EHR. I'm going to have Michelle advance my slides for me. Thanks, Michelle. CMS efforts continue to align the Meaningful Measures initiative. They've added 8 new measures, including 4 that are reported outcome measures, so that's good for those folks that maybe had some difficulty last year finding an outcome measure. They also added one of the new measures is an opioid measures. They're really trying to meet and help with some of the opioid epidemic and crisis that we're seeing nationally. They've removed 26 measures, some popular measures, so you'll want to really look at the measures for 2019 when you're making your selection. I know one that was quite popular was the diabetes foot exam. That was removed, along with hypertension improvement in blood pressure. That one was removed, and again, there were 26. So definitely look at the new measures or the 2019 measures before you determine what you're going to be reporting on. Now, in the past, you had to submit all 6 measures via the same collection type. New this year is the opportunity to use more than one collection type or reporting method. That the collection type is new terminology this year. So for your measure, this is allowing you to strategize a little bit more as you select your measure and you compare your benchmarks. So you could submit maybe 2 of the measures via EHR, 2 through QCDR, and 2 through the registry. Also, we recommend that you submit more than 6 measures. And actually, you can submit the same measure using 2 different collection types if you want. And it's CMS's job to calculate all of this and sort out all of that and then give you the highest score per measure to calculate on your quality final score. Now, there is an exception, of course, for CMS web interface users. You cannot be scored using any other collection type. Sorry about that. If a score cannot be calculated due to there's none applicable to you or available measures for you, the quality category score is going to be redistributed because the final score has to be calculated on 100 percentage points. So it'll be redistributed where improvement activities gets 40%, PI gets 45%, and cost stays at 15%. This applies to those that qualify for extreme and uncomfortable circumstances also. Your score will be redistributed to. And those are the folks like maybe such things as the fires in California. You'll automatically get the extreme circumstances if you fall into the specific zip codes that they announce. Now this slide here shows you the quality submission methods, and this is just using the new terminology. You need to be aware of this new drift of terminology. The first column is submission type. This is how you submit or how you get the data into the portal. And this could be direct for quality category. It could be direct, login, upload, CMS web interface for groups of 25 and older, and the Medicare Part B claims. And this is for this year, Medicare Part B claims can only be used for small practices. Column 2 is who submits, or the submitter type. And I'm not going to read each column other than to tell you what the column headings stand for, since it's new terminology. Column 3 and 4 are collection type. First one is for collection type for individuals. Second is collection type for group. And what that is what is submitted. That's a set of measures or activities, kind of where the specifications come from. And also note that the renaming of the registry measures, it's been renamed to MIPS CQMs. So when you see the MIPS CQMs, it really is referring to what we know them as in the past as registry measures. Next slide, Michelle. Thanks. Their points for a full score is 60. That's not for the CMS web interface users. Each quality measure identifies measure achievement score. The numerator and the denominator are converted to a performance percentage rating using benchmarks. Now the benchmarks are scored on a 1 to 10 decile scale. Performance percentage is then converted to a standard score, and the measure benchmarks will vary depending on, again, your submission method. So it's very important when you're strategizing about these measures that you decide which submission method you'll be submitting on to know what your score is going to be. All measures that you submit will be scored, and the top 6 are used. We kind of talked about that. You have the opportunity to receive some bonus points for other measures. Topped-out measures are capped at 4 points, and they continue to have that 4-year life cycle that CMS applied last year in the final rule. Now, QCDR measures are excluded from topped-out measures, and so are web interface measures. They're excluded, too, from being topped out. They continue with their scoring using the 3 stratification measure classes. Class 1, this class is considered to be complete or all in. You've met the data completeness, and you're going to get at least 3 points, up to 10 points, depending on what your numerator denominator is. Class 2 is the measure that maybe is lacking a benchmark, or there's less than 20 case minimum, but you've reported the 60% data completeness, then you're going to earn 3 points for that measure. So if you don't have enough measures, but you've got one that has less than 20 case minimum, go ahead and submit it. You're going to get at least 3 points for that. For Class 3, this is when you have less than 60% data completeness, regardless of whether you've met the benchmark or a case minimum. Most folks are going to get 1 point for that. If you're in a small practice, you're going to get 3 points for that measure. And that's even if you just submit 1 in your numerator, you're going to go ahead and get 3 points for that measure. So we'll talk about bonus measures for a minute. These measures are submitted in addition to the first required outcome or high priority measure. You will get, for outcome patient experience, you're going to get 2 points. For any other high priority measure, you're going to get 1 bonus point. And then high priority bonus points for CMS web interface reporters have been discontinued, though. You'll also get 1 point if you report that you're doing end-to-end electronic reporting. Small practices that submit at least data on at least 1 measure, they'll automatically earn a 6 bonus points. So that was, in 2018, that was a small bonus point that you got on the final score. Now it's going to be applied at the quality category score. To qualify for the bonus point measures, you must meet Class 1 data completeness on those, though. And then the bonus points are capped at 10% of the denominator of the quality category. You also have an opportunity for improvement scoring this year. You must fully participate in the quality category by submitting all the required measures. They must meet data completeness and case minimum. And then what CMS will do is compare that to your previous year's total quality score and then determine if you're going to receive some improvement scoring bonus points. I want to just take a minute for those of you participating in the Medicare Shared Savings Program ACO that qualifies as a MIPS APM. You'll reap special scoring standards. The weight for quality is 50%. You're required by the Shared Savings Program to report 30-plus quality measures. Certain measures are used to score MIPS quality category. And in most situations, the ACO entity is submitting the quality measures on your behalf. And then the APM administrator, they calculate the score for the ACO contract to determine if you've earned any shared savings. Then that APM administrator, they go ahead on behalf of you, send the web interface measure scores, including bonus points, to the MIPS administrator, and they calculate the MIPS quality final score. So you're really not doing any additional reporting for quality if you're in a MIPS APM. One of the caveats is for MIPS APMs, you have to submit via the web interface, and you have to do the CAP survey. Okay, the next slide. I wasn't able to find an actual list of the CMS measures for 2019 in the final rule. They have removed some. They've added a couple. They've removed, I believe, 5. This is a tentative list from us that I could find from the final rule, but I'm waiting for them to come out with that resource for us. All right, recommendations we have for supporting documentation. These come directly from the 2018 data validation criteria resources. It's mostly important to just be sure that the data report is inclusive of the year-long reporting dates. It has identification on it if your organization or your MPIs, if you're doing individual or group. You want to keep the data for at least 6 years, and you also want to keep a record of successful submission, including a statement from a third party. If you're using a third-party intermediary to submit on your behalf, be sure that you get a statement from them that shows that submission was completed. And also be sure that the documentation is in the medical record to validate the report numbers in case CMS will ask for that information if you're audited. All right, thanks, Michelle. I'll have you move on. We'll go on to the cost category. Good news about the cost category is that CMS continues to calculate this on your behalf, and there's no action required from the clinicians. The cost category is weighted at 15%, except for those that are in the MIPS APM special scoring standards. It's weighted at 0 because you're already being graded on cost through your Shared Savings Program ACO. Calculations are derived from Medicare claims for the 2 measures. You should be familiar with these 2 measures. They used them for your feedback in 2017, and then they're carried over from the value-based program. These measures will be scored for 2018. It's the total per capita cost, which really captures predominantly primary care provider cost. And then the Medicare spending per beneficiary captures essentially inpatient measurement. For 2019, they've added 8 new episode-based measures, 5 procedural and 3 acute inpatient care condition measures. Now, these measures have been field tested over the last 2 years, and they're really designed to fill in the gap of providers that have been left out of the cost measurement category and scoring. So it's, in other words, it's bringing in more of the specialist. Just a quick reminder, the total per capita cost, it measures all the Medicare Part A and B costs during the MIPS performance period. and it's attributed to the plurality of the primary care services rendered by a clinician or a group with a minimum of 20 cases. So again, that captures predominantly primary care clinicians in that measure. And then the Medicare spending per beneficiary, this includes all Medicare Part A and B claims before, during, and after a hospitalization, and it's attributed to the plurality of Part B services rendered with a case minimum of 35. So moving on, the 8 episode-based measures, they're calculated using Medicare Part A and B fee-for-service claims data, and they're based on episode groups. There are 2 types of episode groups. There's acute inpatient medical condition episode groups, and then there's procedural episode groups. The attribution methodology will be the same for all the measures within each type of the episode groups. For the acute inpatient, they'll attribute the episodes to each MIPS-eligible clinician who bills an E&M claims line during a trigger inpatient hospitalization under a TIN that renders at least 30% of the inpatient E&M claims in that hospitalization, and the case minimum is 20. For procedural episodes, it's attributed to episodes in each MIPS-eligible clinician who renders a triggered service as identified like by the HCPCS or the CPT procedures, and the case minimum of 10. Now, to my knowledge, the specs have not yet been published, so we don't know yet what trigger events will be attributed to the cost measures. But we expect those specs out by the end of December. That's what the projection is. Excuse me. We do know that 1 or more clinicians can be held responsible for either the procedural or the inpatient medical episodes. So it can get attributed, especially those hospital ones, it can get attributed to more than 1 clinician. This is a list of the 5 procedural and the 3 acute inpatient medical condition episode-based measures. And if you look at those measures, it really would be hard for a primary care to meet the case minimums as an individual, so that's why it's really pulling in a lot of the specialists. Okay, the cost category for scoring, CMS will calculate the individual MIPS clinician or the group, depending on how you're reporting, their cost performance using administrative claims data, and if they meet the case minimum of the attributed patients for a measure, and if the benchmark has been calculated for the measure. They then compare your performance with the performance of other MIPS-eligible clinicians and groups during the performance period. So in other words, benchmarks aren't based on previous years, such as in the quality category. There's a lot of risk adjustment and analysis that goes into this when they're doing the comparison of you with your eligible clinicians, other eligible clinicians. And then the performance category score is the average of the 10 measures. So if only 1 measure can be scored, the score will be the score for your performance category score. If 0 measures are scored, the cost weight is redistributed to the quality category. I want to take just a couple minutes and talk about the new facility-based scoring mechanism. And again, we'll go into more detail on these things when we do our deep dives into each category. But many facility-based clinician groups believe that their performance will be better assessed in the context of the facility at which they work, such as the hospitals. And these folks most likely would be like your hospitalists, your emergency room providers, your anesthesiologists. You would be considered a facility-based provider if at least 75% of your charges come from places of service 21, 22, or 23. For a group, if at least 75% of the MIPS-eligible clinicians fit the facility-based definition as individuals. And it's attributed to the hospital where the plurality of charges come from. This special status, the facility-based status, will be on the QPP participation lookup tool soon. That's expected to be released, as Michelle said, the end of December for the first determination period, and that status should be on there at that time. Now, it automatically, the importance of the facility-based, or those individuals or groups will be automatically given the quality and cost scores of the hospitals from the hospital-based value-based program to which they are attributed if it is better than the score that they submit for MIPS. to qualify, you must submit at least improvement activity or PI categories data. So you do have to do some work in MIPS. You can't just not see that you're facility-based and just go ahead and say, I'm going to take that hospital-based score. You have to at least submit IA or PI category data. CMS intends to have, anyway, in the final rule, they talk about they intend to have a preview score prior to submission period. They're looking at this summer, even to fall. You can be watching for that. If this looks better than the data that you're going to submit for quality, you may not want to take the time to submit quality data for those for your facility-based individual providers or your facility-based groups, but you do need to submit IA or PI to qualify. I am going to turn this back over to Michelle to move on to the next category.
Thank you so much, Sandy. So now we're going to talk about the promoting interoperability category. And this category really promotes patient engagement and the electronic exchange of health information using certified EHR technology. So the weight for the promoting interoperability is weighted at 25%. If you're in a MIPS APM, it's weighted at 30%. And so even if you are in a MIPS APM, you are required to submit that same data. Now, there is a new caveat that you must use 2015 EHR, a certified EHR, and that 2015 must be in place by the first day of your performance period, but it must be certified. So you may have a version of 2015 that your vendor has put out, but it's maybe not gone through the certification, but you have to start using that 2015 EHR by the first day of your performance period. And that performance period did remain the same at 90 days, just as long as the EHR is certified to the 2015 standards by the end of the performance period. That's really the key. And this year, they have switched to scoring, and so now it's going to be on performance-based scoring at the individual measure level. And when we get into the next couple slides, you'll see much more about what that means. But you probably heard a lot of changes have occurred with this category, and really those two pieces are a big part of that. And so this introduction of this new scoring methodology really is trying to encourage MIPS-eligible clinicians to push themselves on measures that are most applicable to how they deliver care to patients, instead of focusing on measures that may not be as applicable to them. So now, you must report on the measures or claim the exclusions if applicable. And if you do not, you will not pass this category. So we will look at that in a little bit, and there is a total of 100 total category points that end up getting weighted to 25% for the weight. So the data submission, the submission type is either you're going to do that direct, or you'll log in to the portal and upload your data, or you'll log in and attest and manually enter your data. The submitter type can be either individual or group or third-party intermediary. And you must use your 2015 certified EHR technology generated reports to submit that data. So we had this conversation a lot with some of my groups in the small practices this year, more than ever before, about the category reweighting. CMS has tried to allow flexibility, and this is really an area where I think they have done a spectacular job of showing how flexible they're trying to be. So there is both automatic reweighting as well as application options to get the PI category reweighted. And so those that are more common automatic reweighting would be those in those types listed here. But I want to draw your attention to the new eligible clinician types. So not only those first four, but all of the new clinician types will have their PI category automatically reweighted to the quality category, and unless they choose to submit data. If you choose to submit data, you are scored just like anybody else. So just that's the way that they're trying to ease the eligible clinician types into getting used to reporting. And then in addition to automatic reweighting, as I stated, you can have an application that's required, and this is where we did have some of our small practices this year choose to apply and receive, get that grant granted for the PI category to be reweighted to quality. So if you're in a small practice, otherwise extreme and uncontrollable circumstances is also fairly common for those that do apply. Now, you'll notice an asterisk, again, as Sandy had mentioned, with the natural disasters such as the Hurricane Florence and Michael and the California fires. There's the option, they're given an automatic exemption. And I have a link here in the slide for that if that would pertain to you for more information on that. But that would not require an application, but everything else would. In addition, if you're using a decertified EHR or you don't have control over the availability of your certified EHR technology, or you're not able to have sufficient internet connectivity. Now, let's talk about the scoring. So not only do you have to use your 2015 certified EHR technology for the entire period, it must be certified by the end of the period. That's 90 days or greater. In addition, you must submit a yes response to the Prevention of Information Blocking attestation, stating that you will do nothing to block information flowing from providers or to patients. ONC's direct review attestation, saying that you will work with ONC to make sure that the certified product works as it was intended. And then also, this year, the security risk analysis, you will note that it's not a measure that you will see it, but it's not scored, but it doesn't contribute to any points for the MIPS eligible clinician's total score, objectives and measures, but you must indicate that you do have that completed. Now, as I stated before, we need to report on all the measures or claim exclusions if they do apply. And if you have exclusion points, those are reallocated to other measures. And I've gone through and looked at some of those potential reallocations, and we'll see those in the next few slides. And then in addition, we're going to add up all of those individual measure scores together for 100 total possible points. That'll get weighted to 25%. Okay, so here are the objectives, measures, and possible points, and I will just start by saying that e-prescribing and the health information exchange, those first two objectives, those are really what CMS believes to be the core goals for the 2015 certified EHR technology. And you will notice first that you may see fewer measures than you're used to. That's because CMS has removed 4 measures they thought were burdensome to MIPS-eligible clinicians in ways that were unintended. And so they don't want to detract from clinicians' progress on the program's priorities. And so now we're going to take a look, as you're probably all very aware of the e-prescribing. That's worth 10 points. But new for 2019 are 2 bonus point options, and this falls nicely in line with what Sandy was talking about. There's a new opioid measure, and Kelly will talk more about some improvement activities circling around the opioid epidemic. So the first one, querying of the prescription drug monitoring program in your state, and then also verifying that there's an opioid treatment agreement in place with your patients. So those are a total of 20 possible points there. The health information exchange objective, you'll notice that this is weighted with, it has 2 measures totaling 40 points. The first one, supporting electronic referral loops by sending health information. This is what we may know as sending a summary of care. And so that must, when you refer a patient to another provider, you're sending that summary of care from your EHR to their EHR electronically. And so that is worth 20 points. And the second one is supporting electronic referral loops by receiving and incorporating health information. So when you have when you receive patients from another setting of care or patients you never encountered, that's worth 40 points total. Now, the provider-to-patient exchange, notice that this is providing your patients electronic access to their health information, and notice it's worth 40 points. That's how important CMS deems that patients become aware of their situation and they have access to their health information online. So that's going to be key, that you indicate that you have a good workflow in your office from the beginning of your reporting period on offering your patients that portal access. And finally, the Public Health and Clinical Data Exchange. You want to choose 2 from this list of possible registries, and if you choose 2, that's worth 10 points. Okay, we're going to go through some possible exclusion options. The first one that I thought was interesting, there are 2 exclusion options for supporting electronic referral loops by receiving and incorporating health information. And the first one is if you're unable to implement the measure for the MIPS performance period in 2019, that's a possible exclusion. Or if you receive fewer than 100 transitions of care, or you have fewer than 100 encounters with patients you've never encountered before, that's an exclusion. So if that were to be the case, one of those 2, those 20 points from that measure will go to the other health information exchange measure, and to be worth a total of 40 points. So sending that summary of care electronically is now worth 40 points. And so you can see it's going to be very important for everybody to start gathering direct addresses of those providers to whom you refer and to who refer patients to you. Now, another exclusion option is if you have both the health information exchange objectives exclusion. And so this is definitely an option as well, because maybe you transfer fewer than 100 patients during the performance period. If you only choose a 90-day performance period, this may be applicable to you. And so that is also an option. And if both of those you do choose an exclusion, 40 points now roll to providing patients electronic access to their health information. So you can see it is so important for that portal to be offered and having timely access to that within their information within 4 business days. Now, let's say there's an exclusion for you're going to exclude from both of your public health and clinical data exchange measures. Those 10 points then would roll into also providing patients electronic access to their health information. So now those 10 points roll in. Now, if it's just that exclusion, that will be worth 50 points. I do want to note that if you choose an exclusion for one of those public health and clinical data exchange measures, but you answer yes to another measure, you get the full 10 points. And finally, we have a lot of chiropractors that are a part of the program, and so if they were to choose an exclusion, let's say, for the e-prescribing, of course the bonus points are not applicable since they are choosing an exclusion. Maybe they write fewer than 100 prescriptions, then those 10 points would go equally to the 2 measures in the health information exchange objective. They'd be worth 25 points total. I have here the 2 new bonus measures, just a little bit more about those that you can read, and we want to, in the essence of time, go through this. But just so you know that this prescription drug monitoring program integration is not widespread used in the certified EHR technology. There is no existing certification criteria for that, so you may not have that option for you, and so just know that. But CMS is encouraging the state's prescription drug monitoring programs to connect to a free and open source national hub to share that. And that opioid treatment agreement, if there is one in place, then when that Schedule II opioid is being prescribed, that the treatment agreement is in the certified EHR technology. Now, the supporting documentation, of course, you must have your security risk report done every year. It must be dated within your calendar year and evidence shown that it's from your clinician system, like your MPI or the name practice name. And then also show a plan for correcting or mitigating deficiencies with steps that are being taken, and that's a big one. Make sure your policies and your procedures are in place and you're mitigating any deficiencies. Other documentation right from your electronic health record, you want to make sure that all of your reports show the time period, the clinician that is identified by maybe the MPI or the name, the evidence is supported by your EHR, and it may need to include a screenshot of the report before it's printed to show that. Sometimes those reports don't all look the same. Making sure the numerators and denominators for each measure are there. For your public health measures, make sure you have those screenshots showing successful registration or transmission, or that from a letter from your agency showing that the data has been received. And also, if you have any exclusions, make sure you have all the appropriate documentation, and you keep all of this for a minimum of 6 years. So now, I'm going to turn the improvement activities over to Kelly. Thank you. Thank you.
Thank you, Michelle. There were very few changes to the improvement activities category for 2019. The category weight remains at 15%, or 20% for those of you participating in the MIPS APM. In 2019, there are 6 new activities. There are 4 medium-weighted activities and 2 high-weighted activities. The high-weighted activities focus on the opioids, as CMS is doing this year. They are providing patient medication risk education and also following the CDC guidelines for prescribing opioids via clinical decision support. In 2018, there are a total of 118 activities to choose from, so pick the activities that work best for your practice. Remember, you can complete the same activities as you did in 2018. One other change to the program is that due to the restructuring of the Promoting Interoperability category, there is no longer the bonus for using the certified EHR technology to perform an improvement activity. The performance period for improvement activities remains at 90 days. At the end of the performance period, you will submit your data or attest to completion of your activities through the QPP portal or through a direct connection. A full score for the improvement activities category is 40 points. High-weighted activities are worth 20 points and medium-weighted activities 10 points. Those of you in small practices, health professional shortage areas, rural areas, or are a non-patient facing clinician will continue to receive double points for each activity. Those participating as a MIPS APM receive full credit for the improvement activities category and do not need to submit data. Remember, the improvement activities category is weighted at 20% for those participating as a MIPS APM. Improvement activities can be submitted via direct computer-to-computer interaction, such as through an API, by logging into the QPP portal and uploading a data file, or by attesting to completion of activities. Activities can be submitted by an individual, a group, or a third party acting on behalf of the individual or the group. Please note that groups are no longer allowed to report via the web interface for the improvement activities category. For documentation, you are required to keep a record of completion of your activities for at least 6 years. Records can be from your EHR, a completion certificate for training, or documentation of a program you participated in. Activity-specific documentation requirements are found in the MIPS data validation criteria document. One example, if you are completing activity IA, EPA 1, provide 24/7 real-time access to patient medical records, a documentation you may need would be a patient EHR record with a timestamp showing that the care was received outside normal business hours and the medical record was viewed. This is just one example. Remember, please refer to the MIPS data validation criteria document for activity-specific documentation requirements. For documentation purposes, it is also a good idea to save a screenshot from the QPP portal when you are testing to completion of your activities. This will give you proof of data submission. Now, Sandy has some great tips on how to be successful in MIPS in 2019.
All right, we're going to go through these tips pretty quickly so that we can open the lines for questions. But first thing is check for eligibility as soon as it's available, which we said CMS's goal is to have that out there December 31st or early January. If you don't already subscribe to the CMS listserv for updates, which will let you know when it's available, I would recommend doing that. Then determine your reporting level. What best benefits your organization? Would it be to individual or group level? Would it be to opt in if you're a low volume, if you meet the low volume thresholds, or maybe just voluntarily reporting? Set performance goals and financial goals. Do you want to just avoid a negative adjustment, or do you really want to go for the gold? And something new for 2019, when they're calculating and you're looking at your strategizing, the calculation for both the incentive and the penalty is based on Medicare Part B services only now, and drugs and supplies that were billed through Part B are no longer included. So this will affect those folks like our colleagues in nuclear medicine, rheumatology, ophthalmology, oncology, some of those that do a lot of billing of drugs and supplies. They will no longer be calculated for positive or negative incentive. Next, we recommend that you understand each performance category requirements. What are the set of quality measures? What are the specifications? What data completeness criteria needs to be done? Think about using multiple collection types. Would that be of your best interest? Medicare Part B claims, again, are only for small practices. That can be at groups or individual level. And then if you want to submit the same measure via multiple collection types, that's okay too. CMS will choose the one with the greatest measure achievement points. Next, we recommend that you determine the most beneficial submitter and submission types for each performance category, and then analyze each performance category scores. Review and compare. Look at what came back in your 2017 feedback report. Look at what you are expecting for 2018, and then what you project for 2019. Also, if you want to go back and look at your QR/UR reports from 2016, that is always a nice comparison too, and something nice to analyze. If you don't have those yet, they are available still through December 31st. We recommend some performance category tips. The PI category, as Michelle said, is going to be more difficult to score well. You want to keep an eye on the measures throughout the year. You want to perfect to provide the patient's electronic access to their health information measure, gathering your direct addresses to exchange the health information with other providers. And then she recommends that you sign up for your state's prescription drug monitoring program. For the quality category, be sure to check the list, the measure list with the 26 being removed. And then CMS web interface submitters, you want to look at the measures too, because there are less measures and there's no bonus point opportunities. And then watch for your facility-based status and the preview scores for that. If those look good, you may not want to submit quality, but be sure to do improvement activity or PI. And then explore the new episode cost measures a little bit. Predict how they will, how or if they're going to affect your organization. Look for synergies between MIPS and other quality initiatives in which you're already participating. Some of the payer programs, you might want to look at how you can synergize between those and leverage between those programs. We also recommend, as always, that you partner with CMS support contractors at no cost. Let us help you. And just reach out to us. Our contact information is on the next slide for the SURS, and then for the QIO for the large groups. And again, if you're with another state or participate in PTN or need some assistance, we can get you connected to the appropriate person for your organization. All right, well, we have a few minutes left, and we wanted to leave some time for you guys. We just really thank you for joining us, especially during this very busy season. There was a lot of high-level information. Look forward to doing some more deep dive webinars in the future. I'm going to ask our operator, Charm, if she would open the line for questions for us. And while she's getting that line opened, I'm going to remind you that there'll be a survey when you leave this event. Please complete that survey for us. Let us know how we're doing and how we could improve what we can be sharing with you.
We don't have any questions over the phone. Presenters,
okay.
You can continue.
Okay, thank you. Well, from all of us at Telegen, We wish you a happy holidays, and we look forward to working with you and partnering with you in 2019. These slides will be posted, as Michelle said, hopefully by the end of the day. And there are some resources that we used for this particular presentation. Thank you and happy holidays.